I'm Scott Zeger, and I'm a professor of biostatistics, the John C. Malone Professor. So this is my 42nd year. I really knew nothing about public health, even when I took the job. But I had been an undergraduate in mathematics and biology, and then I got a PhD in statistics. And so when I saw there was a biostatistics department, I thought, well, that sounds perfect for me. I didn't know that it was in a school of public health. I didn't know what public health was, but I must say the accident of arriving in a school of public health and making a career here has been one of the real delights of my life. I developed methods that summarize the evidence in data or from a study that's relevant to answering questions about human health. I'm interested in how things change through time, how nature changes through time. So I am a specialist in methods for following people over time and coming to understand the mechanisms that give rise to their improvements in health or their decrease in health. The repeated measurements we make on individuals tend to be more like each other than they are like measures from other people. And so that fact has to be taken into account to make an accurate description of evidence from what we call longitudinal or cohort studies. About 10 years ago, I switched a little bit of my focus. I had had a personal experience where I saw how the American medical system treats an older person who's near the end of their life. So I got interested in whether we can use evidence that comes from clinical research or even from ordinary clinical care to help doctors make better decisions, less biased decisions about what care to provide to, in particular, an older person. So that got me involved in a project called Hopkins inHealth. inHealth stands for Intelligent Healthcare. And what we're trying to do is to change the kind of information that doctors have available to them when they speak with their patients to make decisions about care, especially important decisions that get made, say, near the end of life or when a major disease needs to be managed. My hope is that my current research is that when a patient sits with their doctor, that the data that they rely upon, both the previous data done through clinical experiments and clinical trials, but also the data that that particular hospital has about all of the other similar patients, that data is somehow summarized and available to the clinician. The relevant evidence in that data is available to the clinician so that they make a well-informed decision, not one that's sort of driven by what the financial incentives might be or what the preferences of the doctor might be. So it's to really change how information is used in healthcare. Oh, the people make Hopkins special. It's not just that they're lovely people, as is probably true in many departments, but they're very collaborative, open to each other, lots of both professional and social engagement, both among the faculty and faculty with students and staff. And I think the quality of the people and their willingness and their interest in having a social life together is made very rich. So let's see, my role as an educator is, it takes a few different forms. First, I have 4 PhD students that I continue to mentor. Hopefully they'll be finishing this year or next, and a couple of master's students that I work with. I also have designed many of the courses that we teach our master's and doctoral students over the years, and I continue to be involved with the studies that are about longitudinal the courses that are about longitudinal data. So I think biostatistics is still an essential set of skills, and maybe more important than it's ever been. We're in a transition time We've digitized all the data that gets generated in clinical practice, but we've not really figured out how to learn from it. It's a very exciting time to get beyond just digitizing the information, but actually learning from it and then turning what we learned back into better public health.